Good morning, everyone. Thank you for joining us for the CAPHC Patient Safety Collaborative webinar. My name is Lisa Strongquist, and I'm the Coordinator for Quality and Patient Safety at CAPHC. So before we get started with today's presentation, I just want to provide you with a few of the technical details. So all of the lines have come in muted, so there's no background noise to distract our presenter. And you should notice a question box in the right-hand side of your screen in the control panel. As the presentation unfolds, please feel free to write your questions or comments in as they occur to you. We would like the session to be as interactive as possible. So there will be poll questions and some free text questions that come up during the presentation, and I'll provide a little bit more instruction as those come up. So like all of our presentations, this one will be recorded. It will be posted sometime in the future. We have to wait for the full launch of this initiative, but we'll let you know when it's up for viewing in the future. You can also look for information, more information on the Knowledge Exchange Network with direct links to the Canadian Institute for Health Information and the Canadian Patient Safety Institute. So now I'm just going to hand the virtual podium over to Darlene Bolivar, the chair of the CAPHC Patient Safety Collaborative.
Good morning and welcome everyone. As Lisa said, my name is Darlene Bolivar and I'm the Director of Patient Safety and Risk for the IWK Health Center in Halifax, and I am the chair of the CAPHC Collaborative. We meet monthly at the same time on the fourth Friday of every month. This month we're a little bit early due to the fact that next Friday will be Good Friday. So it's a pleasure to introduce the topic today, Measuring and Improving Hospital Patient Safety, and it's a joint initiative between the Canadian Institute for Health Information and the Canadian Patient Safety Institute. So, welcome to everybody today. I know there sounds like there's a little bit of feedback on the line, so I'll just ask Lisa to ensure that all the lines are muted centrally. So to date, there is no standard approach to measuring and monitoring harm and thus safety of Canadian hospitals. The Canadian Institute for Health Information, CAPHC, and the Canadian Patient Safety Institute are working to address this using administrative data to develop a new way of reporting and improving on patient safety for acute care hospitals. This collaboration will provide significant benefits to patient safety in Canadian acute care hospitals. What we hope to cover today is why measuring hospital harm is important and how it's measured, what the work has been to date, what the deliverables are, and when the release of this information will be available. We have two speakers with us today, Anne MacLaurin, who is the Patient Safety Improvement Lead for the Canadian Patient Safety Institute. She's responsible for advancing patient safety through supporting national and regional partnerships and coordinating initiatives such as CPSI's Infection Management National Strategy and National Measurement System, Patient Safety and Metrics. Anne joined CPSI in 2008 as their project manager for Safer Healthcare Now, and later Canada's Hand Hygiene Campaign. In this role, she's had the privilege of working with a group of dedicated, committed health employees at the core of Patient Canada. Our second speaker is Tracy Johnson, and she is the Director of Health Systems Analysis and Emerging Issues. And as this director, Tracy is responsible and accountable for providing the vision, strategic leadership, and client-stakeholder relations to develop analytical products that address priority health information needs and promote pursuits. Ms. Johnson has held several senior positions at CIHI, most recently as the manager of the emerging issues and also with wait times and special projects. Prior to joining CIHI in 2005, she worked in quality and risk and hospital management, acute care, and rehab as a physiotherapist. She holds a Master's of Business Admin from the Schultz School of Management at York University and a Bachelor of Science in Physiotherapy from the University of Toronto. So as you can tell, both of our speakers today are well-versed in the topic that we're going to be covering, and I'm going to throw it over to them now to do the presentation.
Thank you so much, Darlene. Tracy and I are both absolutely delighted to be here and to be able to share this initiative with you. This has been quite a journey for us, and we're just thrilled to be at this point in time where we can actually start to share some of the work that we've been doing. Darlene has already briefly covered the outline of our presentation today, so I'll just carry on. So I think it's important to start off with having a good of an understanding as to why this indicator, this work, is important. We know that while most patients experience safe care, there is a small percentage of patients that do experience some degree of harm while they're under our care. And while this harm does occur, when this harm does occur, there is significant impact on the patients, families, and also the providers of care. And we also recognize the impact that it has on our health system. So currently to date, there's really no easily reproduced method for monitoring harmful events in Canada on a regular basis. We do have a mix of small dots. We have some voluntary reporting. We have chart reviews. We have global trigger tools. We have safer healthcare now process and outcome measures. But to date, there's not any one large dot way of measuring harm. We do recognize how important it is to be able to measure. Measurement for improvement is key to advancing patient safety. Boards and decision makers currently don't have a way to quantify patient safety currently in Canada. And so our aim through this work is to be able to fill that gap in reporting and monitoring harmful events in Canada. So when we got started early in the days back in, I believe, 2012, we started with a question around, can we measure the rate of adverse events in Canadian hospitals using administrative data? And we're pleased to say that, yes, we can do that, and that's what this initiative is all about. Our partnership between CPSI and CAPHC began back in 2012. CAPHC, through their years of experience, brings a tremendous amount of measurement expertise, and CPSI, with our patient safety background, quality improvement background, brings that improvement expertise. And as a result, we have created a big dot indicator of hospital harm that is very closely tied and linked to evidence-informed resources for improvement. At the end of the day, we have created an indicator that we are calling the hospital harm indicator. And it's defined as the rate of acute care hospitalizations with at least one occurrence of unattended harm that could have potentially been prevented by implementing known evidence-informed practices. And later on in the presentation, we'll provide you some more detail around the indicator and the definition. So through this work, CPSI and CAPHC have consulted extensively on the terminology of this indicator. It has brought to question, how we've arrived at this particular name, and so this is just a few bullet points that help explain how we've arrived at this name. First and foremost, it aligns with the WHO International Classification of Patient Safety. Harmful incidents through their classification has replaced the term adverse events. In conversation and consultation with the Institute for Healthcare Improvement in the United States, we've determined that they have started to use the term harm as they believe it more correctly reflects the patient's perspective. And we have also consulted with patients here in Canada, and their feedback to us was to call the indicator what it is. And so through this consultation, we have arrived at the term for the indicator, calling it the hospital harm indicator. So through this initiative with CAPHC, we've developed three main products. One is a facility level indicator. The second is the improvement resources, which links each one of the indicators to evidence-informed practices. And the third product is an analytical report that will be used to introduce the indicator and the improvement resources with results presented at a national level. And we'll go into a bit more detail on each one of these products throughout the presentation. So this slide gives you a snapshot of the work that we have been doing since 2011 to bring this indicator alive and to the point where it's at today. So this work got started back in 2011 with CAPHC doing initial feasibility and testing and analytical exploration. They then contacted us at CAPHC and initiated our partnership. In 2012, we reached out to 7 pioneer hospitals in Canada to help with some initial testing of the indicator. And very pleased that the IWK was the center that assisted with this and bringing that pediatric perspective. So following the feedback that received from that initial pioneer testing, we then went and did some clinical mapping. And we were very pleased to have Dr. Ben Chan help us with that, mapping the indicators to evidence-informed practice. So then we moved on in 2013 to, once again, data quality and coding review based on this second iteration of the indicator. And from there, we did a second round of testing with our pioneer hospitals. And I'm very pleased that these pioneer hospitals continue to work with us to help refine and get the indicator to where it is today. In 2014, we then worked with clinical experts and advisors from across the country to help through a modified Delphi process. And through that, we did a survey, we did in-person meeting, and once again, that was around further refinement of the indicator. We got started on the report, the analytical report, and review of the findings with clinical experts and advisors who continue to work with us as we get ready to release that analytical report. In 2015, CAPHC embarked on a re-abstract study, and we did some chart reviews at hospitals to check for data quality specific to the codes and around the indicator, which once again, all of this work help with further refinement of the indicator. So that brings us to where we are today. In 2016, in February, we released all of the data to the hospitals, and we have a great commitment from select hospitals across the country to help with that data validation process. And while that data validation process is underway, we're also consulting with some obstetricians, leading obstetricians in the country, to further refine those OB clinical groups. So now I'm just going to move on to tell you a little bit about the actual indicator. So we're calling this Big Dot indicator, hospital harm, and what it is, it's a new facility level indicator intended to monitor variations in patient safety just in the hospital's acute care hospital settings. It is really designed to assist organizations to identify patient safety improvement priorities and to track their progress over time. So once again, the definition is acute care hospitalizations or patients with at least one unattended occurrence of harm that could potentially been prevented by implementing known evidence-informed practices. And 3 things to keep in mind with this. Number 1 is the harm must have occurred after the admission to hospital, and it must have required treatment or prolonged hospital stay. The harm must be categorized into one of the 31 clinical groups. In each one of these 31 clinical groups has evidence-informed practices associated with it, and that's how we arrived at the very specific 31 clinical groups, knowing that there are evidence-informed practices linked with those, knowing that if hospitals implement these evidence-informed practices, there is that potential to reduce the incidence of them. And just one final note is that the indicator does exclude Quebec, and it excludes patients with mental health diagnosis.
Selected mental health diagnoses, we'll say.
Okay, thanks, Tracy.
No problem.
So here on your screen, you'll be able to see our indicator framework. What you'll see at the top in the orange box is the hospital harm indicator, what we're calling a big dot rate. Underneath that, we have it broken down into 4 categories. First being healthcare-associated or medication-associated conditions. The second is healthcare-associated infections. The third is patient accidents, and the final one is procedure-associated conditions. These medium dots will be provided to hospitals in a count. So that's important to keep in mind the difference that the big dot will come as a rate, the medium dots and small dots underneath it will come as a count. So underneath each one of these medium dots, you will see a list of what we're calling our small dots or clinical groups. And we recognize that really at this small dot or the clinical group level is where the improvement is going to take place. And these are the areas where we've identified the evidence-informed practice and have an associated improvement resource to go along with each one of these. Just to keep note that we have orange boxes marked around a couple of our obstetrical conditions groups, and those are just to keep in mind that we are doing some ongoing clinical consultation for these particular groups. Tracy, is there anything else you want to mention about the indicator?
I think you've done a terrific job, Anne. I would say that when you, at the moment for hospitals that are validating the indicator with us, what they have for each of those clinical groups are counts. So that would be the number of events or occurrences of, say, anemia or hemorrhage that happen in the hospital. The buckets, the clinical groups are mutually exclusive, so such that if you have gastroenteritis, which can also be a post-procedural infection, it's been chosen that you're in the gastroenteritis box only, not in the post-procedural infection. The same with things like pneumonia, where pneumonia could be considered a post-procedural infection. You end up in the pneumonia box only, and all other post-procedural infections end up in that category. So just in case people were thinking about what the overlap is. So if you're a patient who has more than one condition, you will be counted in more than one of those clinical groups. I think that's about it for now, Anne, and if there's any other questions, we can answer them later.
Perfect, perfect. So Lisa, I think this brings us to our first poll question.
So pardon me, the poll is up, and we'd just like you to click on the answer that most reflects what's happening in your organization.
We're currently working on any quality improvement initiatives.
What we're looking for here is just a bit of an understanding of what quality improvement initiatives that you may be undertaking in your hospital that aligns with the hospital harm indicator. So think back to all of those small dots, the clinical groups.
Action plan. Interactive. Good work, Nita. I'm going to ask you a list in a minute. Yeah, and I'm going to say, not really. Did you look at them? But some of them are. We do. We measure pressure also. Was in there. Not those. That's specific. Surgical procedural, but not specific anemia or
All right, I'm going to close the poll now, and I'll share the responses. So of all the people who responded, 73% said yes, they are currently working on quality improvement initiatives that might align with the hospital harm indicator. And so for the next question, maybe, and just pop the other slide up just for a moment so people can take another look at it. Might remind them of the 31 individual clinical indicators.
Can you make it big so we can actually see it?
So just take a look at those different indicators, and then I'm going to ask you another question.
And the question that we're going to be asking next has to do with which of these clinical groups do you think requires the most attention at your facility or your hospital?
Well, that's a little hard to do that.
It's not
applicable.
I'm not sure whose voice we're hearing, but somebody seems to be not muted, and I'm not sure. According to my list here, all the lines should be muted, so I'm not sure whose voice I'm hearing. But for this question, if people could, if it's not applicable, mark not applicable, but if you have an answer, you could just write free text into the question box for us, so that we can maybe see what people are working on or thinking. So we're getting a few answers coming in right now. Birth trauma, sepsis has been a choice for a number of individuals. Medication error. So I'll just close this for now. People can continue to write in their answers, but I'll close this for now. So again, yeah, there's still a lot of the same things. Medication error, sepsis seems to be a repeated theme.
I don't think that comes as any surprise. Those are the sorts of incidents and work that we see and hear through Safer Healthcare Now, where people are working and are wanting information and improvement resources around. So thank you for answering those poll questions. It helps us give us a little bit of insights into what's happening at the hospitals. Tracy, maybe you wouldn't mind just touching on the potential limitations of the indicator?
Thank you. Absolutely, Anne. So all occurrences within the indicator at the moment, all occurrences of harm have an equal weight regardless of severity. And we recognize that things like urinary tract infections are less severe than something like an obstetrical hemorrhage, which might mean that you end up back in the OR. So these are some of the challenges with the indicator and around potential adjustment later on for a facility-to-facility comparable indicator. Differences in documentation and coding practices across hospitals may result in under or over-reporting certain occurrences of harm. What I will say about that is in Canada we have one coding standard. So we spend a lot of time at CIHI ensuring that the coders in the facilities understand the standard and can apply it across the country. But that said, depending on what hits the face sheet, as well as the combination of coding, may result in under or over reporting. We are continuing to work with hospitals to understand and improve the data behind the indicator and develop, as I said, a risk adjustment methodology to improve that comparability. So,
perfect. Thank you, Tracy. So the second project or product associated with the hospital harm indicator is the improvement resources. And this is a resource that CPSI has undertaken with the intent of providing hospitals with resources linked directly back to the indicator. The purpose behind this is kind of twofold. One is we really want to be able to demonstrate the ability for organizations to take action. And the other reason is that we want to make those resources readily available to the improvement teams to help with their quality improvement efforts. So essentially, we want to put those resources right in the hands of the providers so they spend more time, be able to spend more time improving care rather than actually searching for the evidence. Our improvement resources has definitely been a collaborative effort. We have been working with patient safety and clinical experts from across Canada. We partnered with Accreditation Canada to have them include in the resource library their standards and required organizational practices. And we are working with members of Patients for Patient Safety Canada to bring that voice of patients throughout the improvement resource as well. And I'm also very pleased to be able to let you know that we have just recently engaged in a partnership with CAPHC. So we'll be able to bring that pediatric voice into our library. And so CAPHC has kindly agreed to work with us to include pediatric and neonatal information to the appropriate clinical resources. So what you'll find in our improvement resource, it starts with a bit of an introduction, an overview of some very general patient safety quality improvement tools and resources. A little bit around some tips to get you started on improvement and tips around how you would go about using this indicator for improvement resources. And then for each one of the clinical groups, the 31 small dots, we will be providing an overview of what that clinical group is and identifying the goal for improvement. We're going to be bringing in evidence-informed practices, and this is where we're really heavily relying on our clinical experts to help us identify what those evidence-informed practices are, what hospitals can do to help really reduce the likelihood of harm. We are providing some recommended outcome and process improvement measures, and also offering guidance around how you may want to come up with additional measures for improvement. As I mentioned, we've partnered with Accreditation Canada so we can include the associated standards and organizational practices. And towards the end, we provide numerous links to additional resources. So essentially, in the improvement resource, it's just a little guide, a mini guide, to provide some initial direction, and but recognize for the most part, people will to those additional resources to get that in-depth detail that would be required. So here in this slide here is some early initial thinking around the clinical groups that we believe should include pediatric and neonatal information. And what would be very helpful to me and also to CAPHC is to get input from you in terms of, do we have the right boxes circled? Are these the ones that, in your view, do require pediatric information? Are there some that we may be missing, or is there some here that you don't really believe requires special consideration for the pediatric and neonatal population? I believe, Lisa, we're going to use the chat box to get this feedback.
Yes, please. If people can just take a look at what's up on the screen, and then you can just write your responses or your ideas into the question page, just as you did in the last.
And Lisa and what I'll add as people are, it's Tracy, what I'll add as people are documenting and taking a look at the framework we have up on the screen right now, is you'll notice that we have anemia hemorrhage under healthcare medication-associated conditions, as well as under procedure-associated conditions. So different, same name, but different clinical groups. So the first one is anemia hemorrhage related to medications, generally. The second one is anemia hemorrhage related to procedure-associated conditions, so somebody who likely had surgery or some kind of a medical procedure in which they may have had a hemorrhage or a bleed. So there's a number of times where you will see that the clinical groups look like they are repeated, but they are related to the category they are sitting in.
All right, we have a few answers coming in. Birth trauma may be significant for flagging needs for surveillance and potential neural problems with the baby. And there is a question about shouldn't retained foreign bodies also apply to peds?
Mm-hmm. Yeah.
Yes, it most definitely would. And the question is, would the evidence or the actions hospitals take, would that be different for pediatrics versus the general population?
Pressure ulcer, venous thromboembolism, and somebody just said that, yes, it is different for peds.
Okay, perfect.
Yeah.
That's the information I need to have.
Yeah. Unanticipated extubation. CVL-related infection. So we have a list here. I think it's and people can keep writing in their answers as we go about.
Perfect. And Lisa, you'll be able to capture that,
Yes.
keep it in your records?
I can.
Excellent. Thank you, everyone, for your participation in that. As I said, it will be very helpful as we continue on adding pediatric and neonatal information into our improvement resources. So at this point in time, I'm going to turn things over to Tracy, and she's going to enlighten us all around the report that her and her team are working on.
Thank you, Anne. So the report is the third deliverable, the first one being the indicator, the second the resources, the improvement resources that are linked to the indicator, and the third is the report that we're putting out. At the end, I'll show you a timeline for all of our deliverables, but specifically with respect to the report, we had three objectives. The first one was to outline the scope of the indicator and the improvement resources. The second one was really to talk about the number and types of harmful events at a national level and the types of patients who have harm occur and their outcomes. So it's to give a big picture view using this new indicator to look at hospital harm in Canada. We also want to identify how measurement can be used for improvement. So in the final section of the report, we specifically link the data to actions that can be taken to drive improvement. And we look at demonstrating how the data can be used in conjunction with quality improvement initiatives that may be currently underway. So Anne, so we have a poll question. What percentage of patients experience potentially preventable harm during their hospital stay? So it's playing a little game. Towards the end, I'll give you a little bit of a preview into what the numbers look like. So from your perspective, do you think it's 1%, 5%, 10%, or 25%? So this is harm related to those various clinical groups that you saw initially in the indicator.
All right, we'll give people another couple of moments to respond. Tracy, just to clarify, this is for the adult population or all populations, or?
So that's an excellent question. It is all populations in that indicator.
Okay.
So we don't, as a province, we don't have Quebec in there, and we have, when we say selected mental health diagnoses, in Ontario we have the OMERS database, which generally puts people who have mood disorders in a psychiatric bed. We've taken those types of patients out across the country for to even things out. But in general, we have the youngest of the young to the oldest of the old in here from a population perspective.
All right, so I'm going to close this now. And 54 Percent who have people who responded. Let's say 10%. So 31 said 25%, 1% said 15%. 15% said 1%, sorry.
So our data shows at the moment that we have about 1 in 15, or around 6% of patients hospitalized experience one of the forms of harm in the measure that you just saw. The second question was, so of the various types of harm that you can see within the indicator, which one do you think occurs most frequently? So we had electrolyte and fluid imbalance, urinary tract infections, patient trauma, or medication incidents.
All right, the votes are coming in. Okay, I will close it now. And so overwhelmingly from the people who responded, so 62% say medication incidents, and then goes to UTI and electrolyte and fluid imbalance.
That's really interesting. So I think probably you folks are coming up with medication incidents partly because of the population that you're looking at. When you look at it across all adult population, all acute care patients, what we find is we've got a list here and we've given them to you in order of frequency. So electrolyte and fluid imbalance are the most frequent. UTIs, urinary tract infections, are the second most frequent. Patient trauma are third. And of the entire list we have, medication incidents are least frequent. And some of this is related to the fact that it is often harder with administrative data to identify medication incidents. So it may be partly that, but what we're seeing right now is things like electrolyte and fluid imbalance pose a lot of challenges in the acute care population.
Tracy, it's Elaine. I'm just a comment, and this could no longer be true, but at one point in pediatrics, and this is exactly the point you were making, your data are talking about the entire population, but 50% of adverse events in pediatrics at one point were certainly referenced as medication errors. And that's probably where our colleagues on our webinar today are coming from.
Yeah, I would bet that. One of the things that would be an interesting piece of analysis that we haven't done yet is to slice and dice some of our data a little bit more by age groups, various age groups, and we haven't done that.
I think that would be fantastic, yeah.
And I think the other thing is many of the trigger tools combine the medication incidents and the fluid and electrolyte potential harm areas as well.
Yes, and that would be true, Anne. So
that would definitely drive up the overall count for that medication incidence.
Yeah.
Okay, Tracy.
So I'll give you a little bit more. So at a national level in the report, the analytic questions that we are answering are, how often do patients experience harm that might be preventable during their hospital stay? So we said to you, the numbers that we have right now are 1 in 15 hospitalizations, or about 6%. Although our methodologies differ significantly from Baker Norton, when you look at calculations for composite measures of harm in hospitals, we're in line with those. So Baker Norton was 7.5% of patients experience some kind of preventable, some kind of harm, and of that about 35% was deemed preventable. Jackson et al. In Australia used administrative data similar to what we're doing with the hospital harm index, and there they came up with a rate, hospital harm indicator, pardon me, they came up with a rate of about 8.2%. And down in the States, there's some other studies. There's the Spanish study that used chart reviews at about 8.4%. And in the U.S., PERLA did a study using administrative data for one of the health systems, looking at what he called highly undesirable events. So a subset of 14 highly undesirable events. And the rate found was about 7.7%. So we're in the same ballpark, although, as I said, not directly comparable. What are the trends over time? So the rate's pretty steady when we look at the last 3 years of data. Doesn't change much. What types of harm are most frequent? So if you think back to that framework we showed you, we had 4 major categories of harm. And what we see is harm is approximately distributed across all of them. So healthcare-associated infections are proportionally about 42% of the harm we see. Healthcare and medication-associated, 36%. Procedure-associated, 19%. And patient accidents is smaller. That's the falls or trauma that happen to patients, particularly because they're in a hospital. That's only 3%, and that is lower because we do not capture things like near misses or harm that did not require treatment. So things happen to patients often that don't require treatment, and that particular category is smaller. But what this tells us is that harm occurs across all areas of a hospital, so it is everybody's job. Patient safety is everybody's job to be aware of. What's the impact of harm in terms of dollars and extra hospital days, outcomes, deaths, and multiple events? So we know that we've taken a look using our framework and our methodology to try and estimate, when we compare patients who had harm with patients who did not have harm, how many extra hospital days and spending goes into those patients who have harm. And it looks like across Canada it's about 1% of hospital spending, so just over about $600 million. In terms of bed days, it's about 1,500 beds at 100% capacity across a year. So that's about 4 large hospitals at capacity with patients extra bed days, basically. What types of patients are likely to experience an occurrence of harm during their stay? And we know that for medical and surgical patients, the rate of harm is approximately the same. We know that for everyone who experiences a harmful event, about a quarter of them experience more than one harmful event. And we also can see from our data that those who experience harm are more likely to die than those who don't experience harm when they're in the hospital. We can't make a causality, so we can't say that because you experienced harm, these patients died. We see an association, though. So that gives folks a little bit of an overview of the data and what we find. Last but not least, for the last slide, this is our release plan. So in February of this year, the indicator was released for validation within a private environment. As Anne was saying previously, we've had almost 90 hospitals sign up specifically to help us validate the indicator. So what those hospitals have agreed to do is look at one of the categories of harm. It's a large indicator. There's a lot of clinical groups in it, and they've agreed to help us with one category of harm. All hospitals have their data available to them through our preview tool. That validation exercise is continuing on into the late summer. The improvement resources, so a sampler of the improvement resources will be released in April. In May, we have an information session. It's not on here, but we have an information session with respect to the indicator for any facilities that are interested in understanding it. pardon me, I think not. I was thinking early May, and it's looking like the date I'm being told is April 28th.
April 28th, yes.
Yeah. And in the fall, our target is October, and Patient Safety Week is a public release of the report that I've just described, as well as the improvement resources. And through the winter, the indicator is being refined based on the validation we get through the spring and the summer. Through the winter, the indicator will be further refined based on that validation. And then we're looking at somewhere in 2017 releasing the indicator in our insight tool that we have here at CIHI. And I would say the advantage of the insight tool is it allows facilities to drill right down to the chart level with their indicator. CPSI will also have the public release of their website with the improvement resources on it. The validation exercises that we're going through with facilities now and the work that facilities will do using that tool in the insight, or using the indicator in the insight tool, will help to inform where we're headed. The goal ultimately is a public release of this indicator, but there's a number of challenges that have to be met before we can actually do that. So that date is to be determined, and it depends on the validation exercises we're going through right now. So I would say that that wraps up our presentation for today.
Great, thanks very much. I have a couple of questions, and then I'm going to call on Darlene and the IWK team to make some comments. So from Rita, I have a question. How do you define preventable harm?
So in preventable harm, preventable harm was determined. So we don't assess preventability. We assess actionability, I would say. So through the Delphi and the clinical consultation, it was determined that the harm indicated in the indicator right now, the different various clinical groups, were actionable as opposed to preventable. And if they were actionable, then they could potentially be decreased. None of them, though, with the exception of retained foreign body and a few others, your target should be 0. But for many of these groups, we don't understand what the minimum or the lowest level you can get is. There is likely a base level for all of these with which you cannot get below.
Alrighty. And do you look at socioeconomic status, health literacy as factors in terms of who is more likely to experience harm?
We did not do that for this round of the analysis. That would certainly be something we could look at in the future.
Alrighty, I'm going to pass it over to Darlene right now, and then I'll go back to some of the questions that people have shared.
Perfect. Thank you, Lisa. While I'm making comments, I'll just ask if you could open the IWK line. I think Matt Campbell's going to have a comment or two for us as well. So thank you so much, Anne and Tracy, for bringing us this information. I, on behalf of the IWK, along with a couple of colleagues at the time, participated from the very beginning of the pilot. So it's very nice to see where it's come all of these many months later. So in the pilot, I guess one of the challenges was for the pediatric data, and with our low numbers, comparing us to larger with much higher volume acute care adult facilities. So I know a lot of work had been done around that and looking at adjusting for rates. So I think that was really worthwhile. And I guess my question would stem to, do you foresee what the pediatric data could or will look like in the report? And will it be rolled in, or will pediatrics be separated out from adults?
So in the report, all the pediatric stuff is rolled in with the adults. So if you are a pediatric acute care center, your data is included in the numbers that I quoted today. So we're not separating out in the report, because it's a national look, we're not separating out pediatrics and kids. We do separate out newborns, and we will be separating out moms if we get the obstetrical groups sorted out. At the moment, we've just taken moms out of there. We do not need at a national level to adjust, because we're looking at that bigger picture. You need to adjust when you're looking facility to facility, and that is the challenge going forward, not only for pediatric hospitals, but for some of the acute care hospitals who have different patient populations. So that's definitely a consideration as to how we do that and where we go in the future with this indicator.
Absolutely, thank you. Matt, are you on the line now?
Yes, it's Matt Campbell here from the IWK. I'm a colleague of Darlene's, the Director of Quality, Performance and Process Improvement. And I just wanted to provide a brief commentary from the perspective of our organization that, it's been a pleasure to be engaged throughout this process over the past number of years, and recognizing that there has been a tremendous amount of work done to bring us to where we are today. And from our perspective, this is in alignment and complementary to our internal reporting processes and key performance measures on safety. And we look forward to furthering the validation of the indicators, working with our CAPHC colleagues on understanding what opportunities this endeavor will bring forward to our collaborative, and as a result of that, shaping, designing, and executing improvement strategies, and creating a knowledge exchange network from best practice, evidence-informed, that will lead to improved patient care service delivery. So just wanted to provide that lens, and we look forward to building upon this foundational work in the years to come.
Excellent. Thank you, Matt. Lisa, do you want to throw it to questions again if you have some, or?
Sure. There's a few questions that have come in. So regarding hospital harm, will diagnostic errors be considered? And in addition, will clinical deterioration or codes outside the ICU be considered?
So clinical deterioration, I'll start with that one. It's Tracy. Clinical deterioration is captured if you have a number of the conditions. So if a patient were to deteriorate from pneumonia to sepsis, you'll see that, because you'll see that patient land in the counts for each of those clinical conditions. So you can see, if you're looking specifically at a patient level data, the deterioration of some patients. Can you repeat I'm sorry, I should have written down the first part of the question.
Diagnostic errors, will they be considered?
They're considered if they would require treatment, and they are seen in the coding data that way. It's unlikely that, and the way that they would be seen is, I'm trying to think of one. So if there was an error made and a patient ended up, say, requiring some kind of surgery, and then they had anemia hemorrhage, what you would see, so that's a bit wild, but I'm just trying to come up with one quickly. You would see the patient had anemia hemorrhage from the procedure, and what a facility would need to do in looking at whether or not they could change their numbers, they would need to drill down into some of those charts to see what happened. And through that process, evaluation, it might come to light that it was a diagnostic error. So not directly, indirectly we capture them. And do we capture them all? Not likely.
Great. So I have a question from Leanne. Is the primary purpose of the HHI improvement or accountability? Comparison. It sounds from the presentation like the primary purpose is improvement, which is great. However, as soon as you talk about getting the indicator ready for facility comparisons, This was mentioned in this talk. This will trigger gaming and other behaviors that will undermine improvement efforts. Please clarify the focus.
It's a really good question. I would say that primarily our focus is improvement. If you can have something do a dual purpose, which a lot of our indicators do at CIHI, then I think our goal is it's the dual purpose. That's why the investigation for a comparable public indicator. We understand the challenges that go with that, and I think your point is well taken. It is why we are moving slowly and carefully with that. It depends on who you ask as well. So we've had extensive consultation across the country about whether it should be just for improvement or whether it's improvement and accountability, and I would say that the reviews and the answers we get are mixed on that. It doesn't really swing one way or the other.
Great. Okay, so I have
there's a break. When the questions are done, if there's a break in the action, I'd just like to make a comment or two.
Alrighty. If you want to go right now, and I have a couple of questions as well to follow. So.
Yeah, I'll be really quick, and maybe just one comment pertaining to the question that was just asked, which I agree, Tracy, is an excellent one. I think I'm hearing improvement for sure, and CAPHC, as Anne mentioned earlier, is absolutely delighted to have the opportunity, I'm going to say, to bring the specific pediatric lens to the hospital harm initiative. We've partnered with CIHI, CPSI, and Accreditation Canada as well for many, many years in trying to bring that pediatric lens to some of our very important national initiatives led by these three organizations. So again, thank you for that opportunity. I think the improvement and comparability, I see that as an opportunity. Obviously, primarily we want to improve hospital harm. We want to decrease the prevalence of in the many thoughts that we're referring to. But I think for comparability purposes, it gives us another opportunity to perhaps explore best practice or what might be working better. So it's not to create that negative the negative effect of comparing one organization to another, but it's in fact to explore and share what one organization might be doing toward improvement. And CAPHC's national benchmarking program, for example, which Matt Campbell knows a tremendous amount about, is really meant to do exactly that. So I see it as a dual purpose and quite positive, actually.
Great. So I have another comment here, and having to do with the med events. So from Carol, she says, I think the med events, unless they're very severe, aren't making it to the patient record for the coders to be seeing for data extraction purposes. So that's why med events aren't top in the way that everyone thought it would be. And I think that the data is informing the top harm categories is more obvious in the chart, re data abstraction purposes. In my experience, the med events are entered onto a safety report by staff, but very often not also entered onto the chart.
Mm-hmm. And what I would add to that is for the medication events, these are ones that require treatment. So within our data, we can identify and have identified reactions. So there's an awful lot of coded medication reactions, but many of them don't require treatment, so they also do not land in the counts for this indicator.
And it's Anne. Another important piece of information to keep in mind is within our improvement resources, when we start describing how you can start to use this indicator for improvement, we are very much encouraging organizations to look at other sources of data to help identify priorities for improvement purposes. So recognizing that this is one source, but there's also many other great sources of information out there that can help you in your improvement journey.
So how often will the national reports come out?
So the report that you're going to see in October is likely we're not going to do a national report again for a while. It will be a first look at this indicator, but the indicator and how often it's refreshed when we put it into our insight tool is still to be determined. You know, I think from a usefulness point of view, what hospitals tell us is good timing on data they would like to see. When it's in the insight tool, actually, I'm going to reverse that a bit. I've been thinking about how we put out indicators before the insight tool. With the insight tool, every upload of open year data means that you have new numbers, can calculate on an ongoing basis what your counts are looking like.
So then, go ahead.
So that was a bit of a mixed reply. My apologies. So the national report is a one-time thing in October related to talking to people about a new indicator, a resource library, and a look at what harm looks like across Canada. At a facility level, you will be able to see your data on a regular basis as we go forward from the validation period.
Very clear. Right,
so Lisa, in respect for time, I hate to do this, but I think that we need to kind of conclude the webinar and draw the conversation to a close. I'm hoping that either or both Tracy and Anne will provide their contact information, so if people have other questions, they could filter them either through you, Lisa, or directly to Anne or Tracy. I think the level of discussion today is an indicator in itself of this very important topic and how people foresee and are excited about getting this report in October. So that's wonderful. And in respect for everyone's time, I just want to note that our next Patient Safety Collaborative call will be on April the 22nd. So feel free to join us at that time. And as always, if you have any suggestions for future presentations or anything your organization would like to share nationally through this forum, please contact Lisa and we'll do our best to make sure that that happens. So thank you very much again to both Anne and Tracy for bringing us this exciting information, and we'll stay tuned for future information as CAPHC collaborates further on it for the pediatric focus of it. So thank you very much to everyone on the line, and especially to our presenters, Anne and Tracy.
Thanks very much. Have a good weekend.
Thanks, everybody. Bye-bye.